In this recording, we're going to discuss an introduction to articulations. We have two ways to classify articulations, also known as your joints. We can classify them based on their function or their structure. So for functional classifications, we have synarthrosis, amphiarthrosis, and diarthrosis. As we go from one to the next, we increase in mobility. Synarthroses do not have any movement between the articulating bones. Amphiarthrosis have a small amount of movement between articulating bones, while diarthroses are freely movable. We have a wide variety of specific movements that can occur at diarthritic joints. In fact, we are going to go into quite a bit of detail about those specific movements a little bit later. So increasing mobilities, we go from synarthroses to amphi to diarthroses. Okay. Now, structural classifications, we have fibrous, cartilaginous, or synovial joints. Fibrous joints are fastened together by dense, regular, collagenous connective tissue, which is a mouthful. There is no joint space between the articulating joints. These bones are basically just touching each other. Okay. Cartilaginous joints, it will not shock you to learn these are held together with cartilage. Again, we have no joint space here. These bones are touching each other again. And then we have synovial joints. These are diarthritic joints, so these two are basically the same thing. They have a layer of hyaline cartilage on the surface of the articulating bone. So if you think back to the articular cartilage at the ends of long bones, that's what we're talking about here. We do have a joint space here. We call it a synovial cavity. This is a fluid-filled cavity. So these articulating bones, they do not touch each other, and we actually don't want them to touch each other because remember, the diarthritic joints are the movable joints, and so if the bones touched each other, we'd have friction, we'd end up with arthritis. We don't want any of that. So it's important that we have that space between the articulating bones here. Now, synarthroses, okay, remember, immovable joints. We have some that are fibrous joints, and we have some that are cartilaginous joints. Okay, so the fibrous joints, for example, would be things like your skull sutures. Okay, so if we connect your frontal bone to your parietal bone at your coronal suture, okay, if you think about your head, your skull, your big noggin, we don't want the bones of our skull to be moving around, y'all. We would like that to not happen. So we are going to join the edges of the bones that make up the cranium or the back of the skull itself. Again, this is an immovable or a non-movable joint. Now, this one you probably have never really thought about. Gomphoses, which is kind of a weird word. Gomphoses, think of your gums of your mouth. So you have these little joints in between each tooth and the bony socket of the jaw itself. So you can see we have these little periodontal ligaments all the way around the base of the tooth. Boop. You've probably never really thought much about it, but we do in fact prefer if our teeth aren't super loose in our mouths, because that would make it much more likely that our teeth would just fall out, and that would be awful. And so this is a type of fibrous synarthritic joint. We don't want a whole lot of movement there. Now, cartilaginous joints, again, these are all synarthroses, so we are not seeing movement here. The two most obvious places that we have these cartilaginous synarthritic joints are your epiphyseal plates. Okay, so this line right here is connecting your diaphysis to your epiphysis of a long bone. We obviously would not want any movement within a bone itself. Okay, so we don't want the top part of your femur to wiggle. We don't want that. Okay. The other place would be the sternocostal and the costochondral joints of your rib cage. Okay. We don't want your ribs to wiggle around, y'all. Okay? We don't want any wiggling in any of these places. Now, amphiarthroses, remember we have a small amount of movement here. And again, these can be both fibrous and cartilaginous. Okay. Symphyses, for example, you have your pubic symphysis that holds your pubic bones together. Okay. And then we have intervertebral joints, your intervertebral discs. Okay. Both of these locations, we do need just a little bit of wiggle room here. Okay. So we know that collectively our vertebral column has a little bit of movement because we can bend forward and we can bend back, things like that. We do need to have a little bit of movement here, just a little bit. Okay. And then your pubic symphysis, best example would be during childbirth. Okay. We do need for those bones to be able to move a little bit to make way for the baby that's being born. Okay, so we have a little bit of movement here. And then fibrous joints, these syndemoses, you find these between your tibia and fibula, so your bottom leg bones, and then your ulna and radius, your lower arm bones. Okay, these are the ligaments that we're talking about. So we can rotate your arms and your legs just a little bit, and so these bones do need to be able to wiggle just a little bit, but the main movements happen a little bit lower or a little bit higher in the knee or the wrist and elbow respectively. So we don't want your tibia and fibula to completely separate. We just want a little bit of bend so we can move your overall leg or your overall arm. Now, when we talk about lots of movement, we're talking about your synovial joints, your diarthritic joints. These are the ones where we do have the cavity, the space between the articulating joints. Remember, these other ones, okay, these bones are touching each other. These bones are basically touching each other. We don't have the space there. Okay. Here we do have space. We want some space. This is a fluid-filled space. We have synovial fluid within your synovial cavity. The bones that help form this joint are surrounded by articular cartilage. Okay. Even your fingers are technically long bones because they are longer than they are wide. That's kind of it's kind of weird to think about, right? Because your fingers, your toes, they're such tiny little bones, but they are still technically long bones. They do have the articular cartilage on each end to help prevent friction. The synovial fluid helps prevent friction as well. In addition, we also have usually accessory ligaments. Okay, so the ligaments on each side of the synovial joint also. So the most notable, your elbow, your knee joints, your wrist and your ankle joints, but also your hip joints, your finger joints, all of those are technically synovial joints. Now, the joint cavity itself, the synovial cavity, we've already mentioned it is full of synovial fluid. Okay. This comes from specific cells within the cavity itself. We have synoviocytes that secrete synovial fluid. Okay. The synovial fluid, okay, from the synoviocytes is the innermost layer, okay, of the articular capsule, okay, which is this whole contraption here. Okay. The innermost layer, we call that the synovial membrane. Okay, that's where your synoviocytes are. That's where you're going to crank out that synovial fluid. Okay. And you find that synovial membrane, which is a little hard to see, but it's almost like a light purple-ish shade. We have that everywhere except where the articular cartilage is itself. So no synoviocytes here. This would be your hyaline cartilage sites, your chondrocytes, but everywhere else along that inner cavity, you do have that synovial membrane. Okay. We do have a second layer. The outer layer of your articular capsule is fibrous tissue. Okay. This connects the two bones themselves, so we can see that this fibrous layer goes from one bone all the way up to the other bone. Okay. This just provides stability. We don't want these two bones being pulled too far apart. Okay. Now we keep mentioning that synovial fluid. We do have a couple of functions here. The first one is lubrication. We don't want friction between these two long bones. Okay, that's how you get arthritis, and we're trying to avoid that. But in addition to reducing the friction, we also have a metabolic function here as well. We can transport nutrients and wastes through this fluid itself. Since remember, articular cartilage does not have vasculature itself, okay, but we can get blood, or well, nutrients and wastes in and out through the fluid itself from the bones and then the surrounding tissues. Okay. And then we're going to have shock absorption. Okay, so as long as we have plenty of synovial fluid within this cavity, if you, for example, just kind of jump up and down, okay, it would make sense that these bones would almost touch every time you jump up and down, but the articular cartilage and then the synovial fluid helps prevent the bones from actually rubbing against each other. Now, we mentioned the articular cartilage. Okay, we've mentioned it several times. I think we're experts on that by now. We did just mention that the cartilage itself is also avascular. Okay, and so we're relying on the synovial fluid itself for the oxygen, any other nutrients, the waste removals, things like that. You do have a couple of other components for this joint as well. We've got a little bit of adipose. We do have blood vessels in other parts of the synovial joint, just not right here at the articular cartilage itself. And then we do have nerve fibers. Okay, so if you, I don't know, if you damage your ligament here, you can feel it. It hurts. Speaking of ligaments and tendons, since we do have so much movement at these synovial joints, it makes them less stable than your synarthritic and amphiarthritic joints. So we do all that we can to help reinforce and stabilize these movable joints. The one or two of the ways that we do that are the ligaments and the tendons. Ligaments themselves are dense regular connective tissue. We're going to connect bone to bone. Okay. Tendons, on the other hand, although they are dense regular connective tissue also, now we are connecting muscles to bones. Okay. Because we are working with muscles, your tendons will cross over the joint, okay, to provide stabilization when the muscles are contracted. So let me go back. So this ligament, this white line, connects one bone to another. Okay. Your tendon, if we had one here, if we were trying to attach your quadricep muscles, we would start the tendon up above the knee, and that tendon would have to cross the knee joint, and it would end up, the bottom of it would end up down here. That way we can still bend the knee, okay, without ripping apart the joint. Okay, so tendons are going to cross the joints. All right, we do have a couple additional ways that we can further stabilize these joints in certain locations. We have bursa and we have tendon sheaths. You tend to find these in the higher stress regions, so you're not necessarily going to find these like in your fingers, okay, but you would find these like in your shoulder, for example. We have a lot of movement, repetitive movements in our shoulder. So your bursa are additional synovial filled structures that help minimize friction between moving parts. So here's our bursa here. Okay, this is just an extra little sac of synovial fluid because this is the joint itself. So that, again, this is an additional structure. Okay, and then we have a tendon sheath. This is kind of a long, skinny bursa that surrounds the tendon itself. And again, both of these are helping reduce friction where we have a lot of this movement. So think about all the movements that your shoulder can do. We wouldn't want to basically continue to have friction on the tendon, because the tendon, we could eventually like wear through the tendon. We don't want that. So we've got this tendon sheath to help reduce friction. We've got this bursa to help reduce friction here as well. Now, it will not shock you to learn that sometimes things can go wrong. All right, we keep talking about how we're trying to prevent arthritis, but arthritis is still pretty common, so eventually we will have some bone-on-bone action. Arthritis itself is basically inflammation at one or more of your joints, which is very painful and limits the movement at the joints. There are quite a few different types of arthritis. We're going to discuss just a couple common ones, but there are quite a few. Osteoarthritis is the most common. This is the one that tends to be associated with just normal wear and tear as we get older, or you could have suffered an injury that maybe destroyed your articular cartilage or something like that. You get a lot of pain, your joints get stiff, you could even lose mobility. Okay, these are some of the common places that you see arthritis, and you will notice that these are your synovial joints. Okay, so we have worn away our articular cartilage here. You would have some bone-on-bone friction going on. You could also have a reduction in synovial fluid because perhaps you have damage to that synovial membrane that we've mentioned as well. Now, rheumatoid arthritis is a little bit different. This one is an autoimmune disorder. So now your body has started attacking its own joints. This is very common in your hands. Okay, so you can see these giant malformations at this person's joints. This is obviously very painful. And since it is autoimmune, we don't necessarily have a cure. There are treatments, but there's really no cure for this yet. And then we have gouty arthritis. So gout, a lot of people have heard of gout, but don't necessarily know what it is. So gout is by itself caused by uric acid crystal deposits. Okay, now, don't ask me why, but uric acid crystals love to be deposited in people's big toes. Like, not their pinky toe. Like, not your pinky toe. Like, your big toe. I don't really know why, but they love it there. And this creates inflammation. Okay? It creates inflammation. It also, the inflammation itself, when your body tries to fight off the inflammation, you will also a lot of times end up with bone erosion at this joint as well. Okay? So here's kind of a real world example of those deposits. You can see the most common location is your big toe, but we do have some other common locations. Less common, your shoulder and your fingers. I don't really know what it is about the big toe, y'all. First toe eventually affected in over 90% of people with gout. Okay, this is super, super, super painful. Okay, so if somebody suffers from gout in their big toe, do not touch their toe. Just don't do it. Okay, because they're liable to have a very negative reaction towards you. This tends to affect people with diabetes. Okay, so it tends to be a comorbidity with people with diabetes, but ultimately this is an inflammation reaction. Okay, so there are medications that can be used to treat the inflammation. Also treating the diabetes could help reduce this as well.